Technology. He is a graduate of the U.S. Naval Academy. He's also, go Navy. He's also an adjunct professor of health IT at George Washington University, where he has to head back to this evening. And is Chief Medical Information Officer at the Department of Defense Veterans Affairs Interagency Program Office, and a board member of the American Medical Informatics, that's the Information Association, AMIA, which you will see more and more as time goes on. He's also a member of the American College of Physicians Health IT Committee, which is sponsoring, is the primary sponsor for the new board in health informatics or clinical informatics. So please join me in welcoming Dr. Weiner. You turn your mic, yeah, so be sure. There you go, Randy.
Am I on? There we go.
That's better.
So right down the road at the dive school, I needed an age waiver to go to Navy dive school, which was already an indicator of things that were going to go horribly awry. So they would put us at the end of the pool, and I don't know if you've seen movies on Discovery, and they would put us at the bottom of the pool on our hands and knees and in scuba gear, and then you'd hear like a little Timex watch, beep, beep, and the instructor had 2 minutes to just abuse us to any way that he wanted to. It was just horrible. And every time I come to land into the area, I have those flashbacks. But Destin is beautiful. It's like a little cove of perfection. I'm the Chief Medical Information Officer at a little startup out of Armonk, New York called International Business Machines. I don't think it'll come as a surprise to anyone. I mean, you've seen it in your hospitals, your practices, you've seen the policies, you've seen the news. You know, computers have made their way into our practice. And I think, my personal take, I think for too long it was led by the IT department, and it just hurt us so badly. And a position was created that brought together the IT department and the clinical community, and that's a Chief Medical Information Officer. And I say that if your hospital or institution does not have one, I highly recommend you finding one to be able to have a conversation with the IT department. And the IT department should not be in charge of your EHR install. If you're already past that, it should be moved over to the department that has a clinician in it. One of my previous gigs was I was the director of clinical informatics for NATO, and I say that only because I want to share with you the whole world has the exact same issue. Period. Right. So everything we're going to talk about today, Germany's working on, France is working on, Ireland's working on, Switzerland, everyone. No one has the money. I go to Ireland and they're like, we need to really do this whole thing on like $60. What do you recommend? I'm like, oh yeah, that's not going to work. Like, good luck with that. So, you know, it's an expensive journey, but everyone has these issues. So I'll go over a couple things just to sort of lay some groundwork, but I just want to get everybody, I love this. What is everyone's thought? What kind of time is it to be in healthcare now? Terrible. Terrible? Oh, I'm going to take that one. I like that's challenging, terrible, confusing. Sir?
Interesting. Remember the curse, may live in interesting.
Right, interesting, right. Now, I have to tell you, somebody in the IT side of it, like, I think it's really exciting. So, you know, we are where the banking industry was 15 years ago, where the aviation industry was 15 years ago. I mean, like, we're all having to suffer and get through it. We're like an adolescent, if anybody's got kids of that age, right? Like we want to break out on our own, but we're just not there yet. So I think it's an exciting time, but it is challenging. It's frustrating. There's moments where it's just terrible. It's horrific. But I'm going to say it's an awesome time to be in healthcare. So, you know, Wayne Gretzky, where's the puck going? So I just thought I'd share with everybody, I'm privileged to be able to go out and talk to many of the CEOs of some of the hospitals around the country, the CIOs, the physician teams, the IT teams. I'll just share with you sort of what everybody's thinking. Nothing mind-blowing here, all right? You're going to be like, yeah, I know. But I'll just give it to you in a sort of foundational context, and then let's talk about sort of what we're all going to do together to address the issues and challenges. And then, just because you were all kind enough to come this afternoon after lunch, I threw in a couple of slides from the Office of the National Coordinator. I met with them yesterday, and Kelly Cronin, who's running healthcare transformation at the Office of the National Coordinator, had a couple of slides she thought would be interesting to share with everybody. So I put those in. And it's all consistent with sort of where we're living our world today. So the challenges, again, I think everybody, you live these every day, right? This is our practice. The challenges are, we have an aging population, we have more technology being thrown at us every day of the week, and we're being presented with new care models. Right? Some of them we feel like are new and weird, and we don't buy off on them, and others are like, well, we thought we were doing those already. We just maybe weren't getting paid for them the way that we had hoped for. So aging population, there's so many sides to the aging population. There's we're just getting older. And this is a global issue. Nigeria has an aging population. Their aging population is 47 years old, but it's still a burden on their country because they're not used to this many older people. Scotland has, they're going to have an 80% growth of their above 65 in the next 10 years. Right? Just, what do we do with all these extra patients? And with those extra patients comes some new Western problems. With those new Western problems, we all face these together. Our colleagues to the south, I think this year beat us in obesity. I'm certain we'll give them for a run for their money in the upcoming years. And then, again, we all know, but the number of chronic diseases. So we have an aging population, we have more diseases, and then here's the one, I would tell you we probably all could have flown under the wire on just those two things, right? Like, yeah, great, like more patients, we're in on this, like, let's do it. This is what got everybody's attention. So I spent the last 10 years in Washington, D.C. I was on the Meaningful Use Stage 1 Policy Committee, and a bunch of other sort of government agencies. This is what got everybody's attention, right? I mean, this number, the top number of 20% of our gross domestic product. Again, nothing you worry about on a day-to-day when you're practicing, you're seeing patients, you're trying to take some vacation time. But I'm just telling you on a national note, this is why we're all getting this, what's coming out of D.C., right? It's this. And this is every country. The GDP of Japan projected to be 20% due to health care. Their problem is everybody gets an MRI when you walk in the door. I used to train Japanese interns. I was stationed in south of Tokyo. We tried to bring in like some American discipline into our morning report with the Japanese interns. They'd present the patients that they admitted overnight, and in the morning we'd say, so what would you like to do with Mr. Jones? Like, well, he needs an MRI. What, did you want to talk to him or examine him? They're like, after the MRI. Highest per capita MRIs in the world. That's what's breaking their bank. And then what do we get for that? This is, again, the other signal that is being noticed, and that is our infant mortality isn't wonderful. I think there's a little bit of reporting bias, right? I mean, where would you rather have a child, in China or here? But these are the numbers that have come out, but this number I think is legit, and this is the one as I'm about to break into the second phase of my century existence. This is the one that personally concerns me. This is the 12.1% of my life will be spent potentially in some sort of not being perfectly healthy. I was at Whole Foods yesterday. There was a woman we were checking out, about to get in the elevator in the city. You know, everything's compact and floors. So the woman turns to, obviously it's her mother, and her mother says to her, "I'm going to take the stairs." She's like, "I don't like the elevator." We get in the elevator and she goes, "Oh, my mother, she's 92, she hates elevators." And just fit as could be, right? So she is living the dream that we all want, that's mortality compression, right? Like we just want to be healthy right up until we're not healthy, and then that's it. But that's not what we're getting. And then this is just driving the cost. And then, you know, the other numbers that are being noted that, you know, we all have to bear is, why is there such a cost difference of care in the country? This is Medicare, Medicaid dollars, but, you know, there's a cost difference. So how do we, you know, again, aging population, more patients, more chronic disease, and there's just a cost, and it doesn't feel like we're getting our value for the cost, right? Again, at a local level, I think, you know, we can argue this and dispute this all day. It's just sort of these are as the numbers roll up. My mother is a 74-year-old nurse, 4 days a week. She's like, I kind of like a day off nowadays. 4 days a week. I'm like, "Mom, how long are you going to do this for?" She goes, "I think I have a couple more years in me." She moved to a surgery center. She used to be an ICU nurse. She's very happy. But if you look on the right, there's this care gap, people over 65 versus women 25 to 45. You know, women have traditionally been in the nursing field, and there is just a gap coming. Who's going to take care of us? Who's going to take care of my mother and my father? And then projected supply and demand of physicians, you know, once again, a gap. So aging population, increased chronic disease, so there's a pent-up need coming, and then there's not the physicians behind it, right? There's not the nursing staff behind it, right? And it's costing us a lot of money, right? So this whole ecosystem, this milieu, is what's driving, I believe, is driving the solution, which is health information technology. Now, I'm on my medical school board, and all my colleagues that I went to med school with, they know that I'm in IT. They know that I was doing some work for Meaningful Use, and they all take the opportunity to push me against a wall. Or I'm like, "Melissa, why are you so mean to me?" She punches me, and she's like, "Oh my God, I will personally, Michael, be the last person in America to have an electronic health record." I know that it's certainly not the perfect world we want, but there is a vision here of what health information technology can provide to solve the increasing demand, increasing cost, okay? Again, we are not there today, so I want to share that with you. We're not there today. I know. I've installed, I've used, I know. They're horrible, right? I got it. But there's a vision, and that's all. I just want to walk everyone down what I think that vision will be, where I think the government's taking us, and where I think technology is going. So here, you know, back in 2006, Chaudhry, this is in the Journal of American Medical Informatics, said, you know, HIT is a promising tool for improving the overall quality, safety, and efficiency of healthcare. McClellan in 1976 said the same thing. So we've all been thinking it. And I think, you know, it wasn't until 2009, 2010, when the country was in serious economic and money was pumped in, and that finally, you know, under the HITECH Act, some money was put in to back up buying an electronic health record and really getting the country on a digital pathway. Right? Oh, we hate change. I love the speaker before. You know, we just don't like change. Like, it was so much better when I wrote it on a piece of paper. I mean, I think we could, you know, we can dispute that one way or the other. I will just say the millennials who are seeing patients today, when the system goes down, like, hey, just write a prescription. It is now a concern in America in 2014. They don't know how to do that. They literally don't know what to do with the piece of it. You're like, just put SIG, 1 PO. They're like, I don't know, like, right? Nobody knows what to do. So we're in, you know, some of it's a little, there's just a generational change occurring, but it's coming. Right? So I'll just share with you, and so how do we all get through this and come out the other end? Again, here's the big promise. Increase quality care and reduce cost, right? It's This is it. I mean, our guiding principles as practitioners, I love the decreased paperwork one. I just haven't found that I decreased paperwork since going electronic. And I come out of the military, and we were on an electronic health record for 3 decades. But, here's, I think, what really has given us a bad rap. Everybody we know, including ourselves, has an ATM card, and we're like, I don't get it. I can do my banking online. I swipe my ATM. But there was a time when we didn't. I remember as a kid going to the bank on the weekends and to get the money that was needed for the week. It was a paper system at the time. I can't remember the last time I wrote a check. Right? Again, I think that was just before us. I mean, there was a time you had to go to a travel agent to book a flight. I mean, I haven't talked to a human being in a bank or a travel agent in, 5, 10 years. And I say all that because I think that's where we're headed, right? This is it. So a little bit of technology is going to drive our business. But the reason I think banking went before us is because, it's only 2 decimal points at the end of the day, right? Like something, 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 period, 0, 0, 0, 2. I mean, like on a technology note, not super complex. This, as we all know, is much more complex. Right? So, and I think trying to capture this has been, it's been a challenge. I'll just say that. I mean, we're in the middle of 15 different standards for what a sodium is. I mean, I'm being nice. It's a work in progress, right? And that's, if you wake up in the morning and you're like, oh my God, I hate my EHR. I mean, it's a work in progress. So, I think where we often lose sight of it, and I'll go back to why I think this, having someone to communicate in between the clinical and the IT department, because these are actually healthcare projects. And I think initially we thought we were installing PowerPoint, and we're like, give the physician a disk, and it's PowerPoint, and then they'll figure it out. Right? But it was much more, the workflow is much more complex than creating a slide. I mean, this is, what we do together is difficult. Gartner, Vi Schaefer at Gartner, her statement, she's their lead healthcare analyst, healthcare is 1,000 times more complex than the aviation industry. So getting the new 787 Dreamliner out was 1,000 times easier than getting a patient through the ICU. Right? I don't think anybody in here would deny that. I just don't think anybody else in any profession understood that. Right? I mean, if I have to take one more IT guy who's like, I don't know why you doctors are making it so hard, I'm like, I would tell you, but I won't enjoy it as much as if I just let you roll for a little while. So, I can clock it on my calendar. I put a little note on my calendar. 180 days later, they all show up in my office. They're like, oh my God, holy cow, what have you guys done? I'm like, okay, now we can have a conversation about the complexity of healthcare and the healthcare workflow. So more technology, I mean, just more technology. I mean, it's just more and more and more, right? I mean, we already knew the most complex, you go to the OR, go to the ICU, and then, patients show up and they're like, here's my Fitbit data. I'm like, great, yay, I don't know what to do with all, right? I'm hoping we'll be able to automate this in some way. I mean, and, the venture capitalists, everyone sees healthcare, there's 2.8 trillion in healthcare. Everybody's like, I want my piece. And there's a venture capitalist who's not working to do something implantable, swallowable. You pick it. Everyone's working on it to give better health. No idea what they're doing, but everybody's pushing forward on it. Now, I will say I'm in the middle of having my parents are getting older, and I'm having the house wired, and for sensors for just their life flow. Okay, just make sure that they get up each day, walk around the house, and everything's normal. And I'll tell you, there's a hospital system out in Sioux Falls, South Dakota. I'm the new guy at IBM, so they're like, hey, it's December. Why don't you go out to Sioux Falls for a couple of days and go talk to a Good Samaritan Hospital? I'm like, isn't South Dakota just really terrible? Like, no, it'll be good. You'll enjoy it. So Sioux Falls, the folks in Good Samaritan, they wire the house, they watch a patient, and they have a way to see if a patient's been up. If they monitor them from a couple of days to set a base level. And then if, Mrs. Smith gets up up 6 times during the night and she normally would get up at 4, they sent a very sweet high school graduate care coordinator to her house or to call her to see how she's doing. And what they've been able to do is they've been able to sell that service and technology to an ortho team who is being paid for by bundle payments. Right, so again, you're going to start to see, so I'll give you a trend, you're going to start to see healthcare moving out of the clinic, out of the hospital. It's going to start moving home. Moving home, right? So this is just step 1, whether my mother gets up and walks around 3 or 4 times during the night. Step 2 is a blood pressure cuff. I mean, the technology is there. And people are doing it. It's just niche business because we really haven't been reimbursed for it, but the reimbursement's coming. So that's why I want to share with you. So here's the technology, and then the reimbursement's coming behind this. So with all this new technology is all this new information, and I'm going to give just one little aside. Most of that information is non-structured. So non-structured is what's in a Word document. Structured is when you're using your electronic health record and there's a drop-down menu and it says male, female, and you pick one. That's structured. Right now the computer's like, I got it. I understand that piece of data. But when I use Dragon dictation in my EHR, and when I write in 24-year-old white male presents 5-day history of nausea, vomiting, fever, chills, right, that's unstructured. That's just a word blob. That's where most of the data in the EHR is, right? And when I say most, 85% of that. So 85% of that data, and I'll come back to that in a second. And, you know, if you, as a physician, wake up one morning and you're like, man, it just seems like there's a lot more info out there. There's a lot more info out there. That's why you're feeling that. And, you know, here's the number. When I was, let's say I went to med school in the 80s, I was told, like, hey, you just need to read one article every night before you go to bed. You'll do great. It's all going to work out for you. Right? Now we're at 1 million cataloged articles a year. 1 million. Right? I mean, I couldn't keep up with 365. I took a little holiday. But 1 million. Right? So how do we collectively tap into all that? I mean, we tap into some of it with UpToDate now. We tap in, you know, I mean, depending on what clinical decision knowledge support you use. But, I mean, there's 1 million of them being presented a year. And then I'm just going to sort of give a tip of the hat. And then the genome, right? You can go to 23andMe and get your genomic profile. It's coming, and it's a lot of data. And what do we do with all that? Right? Again, right now I think we have little snippets where, like, oh, you probably can't take Plavix because if you're at a hospital where they'll do the genetic testing to see if Plavix works on you or not. But this is going to just bust wide open. So here's what again, we can talk about the design of EHRs and where they're going and the use case and the workflow, right? And I will agree with all of those. But the reason our government is paying money, and they put a significant, 19 to $20 billion on the table so that we would all go buy an EHR for stage 1 meaningful use. They didn't say buy a good one, but buy one that you like, buy one that you feel made you more efficient in your workflow or got you home earlier, your dog didn't love you more, you were a little more frustration, but they're like, hey, we'll give you a little money for this, right? And it's because we want the data. So with that data, we believe we'll be able to create some information, we'll have insight, and then ultimately we will have knowledge. So, I think it's mandatory in any IT talk to talk about analytics. So what is it? So I'm just going to give you use cases just to take to your office on what analytics is. Right? So you got to have a something to put data in, right? So we'll call it a trusted information platform. Call it your electronic health record. Call it your Excel spreadsheets, right? You got to put data into something. And then a dashboard is nothing more than a dashboard in your car, right? It just tells you, because I would offer many physicians in America don't even know who their patients are. They just don't know, really have a sense of, I do 50,000 patients, but who are my patients? Right? Who are they? How many are diabetics? I mean, just on some simple dashboarding, who are my diabetics? And if I know who they are, how are they doing? What are their hemoglobin A1Cs? Let's just start there. That's a dashboard. I see 50,000 patients in my practice, in my group. I have 5,000 diabetics, and here's the hemoglobin A1Cs. Right, then all of a sudden you're like, I think that may be useful information. Right, so just again, present it up to you. I think ultimately, again, I want to keep it in terms of real world. We are going to be paid for that group. Right? And we will either be incentivized or not incentivized, depending on how that hemoglobin A1C is going. And so I want a little fair warning on this. Number 2, predictive. Carilion, Virginia, Carilion Hospital in Roanoke, Virginia. I just think this is so cool. I don't know what to do with the data, but I think it's really cool. So they're on an Epic EHR. They're on an Epic EHR, utilizing a thing called natural language processing. Went through and read, so the computer read 800,000 records. The blob out of the records, right? So it took the structured data, male, female, zip code, and which is structured, and then it took that blob and pulled data out of the blob. Ran it through some research models, and we're able to predict to 88% certainty the community of patients that were going to develop congestive heart failure that had never been diagnosed with it before. So we were predicting who in the community, whose pump was going to fail. I think that is, it's scary, it's exciting, it's interesting. So are you saying we can start to predict things? We can start to predict things. Right, so if you can predict who's going to get congestive heart failure, you can predict who's going to get readmitted for congestive heart failure, you can predict who's going to have renal failure, you can, let's start predicting disease, because we're going to want to capture them early. Again, payment models are going to catch up to this knowledge, this technology. So right now, Carilion is, they're like, well, what do we do with this? Do we send a text? Do we email the patients? Do we call them? Ms. Smith, hey, we were running some analytics, and it appears your ejection fraction is about to drop. So it puts a whole new set of problems on the community, but it's interesting. I might confess it's a little interesting. Big data volume. So this is my particular favorite. ICU. Take all of the different machines that our patients are hooked up to, and feed out the data out the back into one magic box, and then make predictions off of that data in real time. Right, so we're doing this up in Columbia. We're doing it in the neonatal intensive care unit up at Sick Kids, at the ICU in Emory, and at UCLA. So it's called streaming. So the data is just streaming through it so much. Think what comes through on telemetry. And I mean, it's just amazing the amount of data. Nobody knew what to do with it before. I'll tell you where the technology comes from, because it's very interesting. So post 9/11, there's a lot of chatter going on over the internet and over phones, and the government wanted to be able to pull data out of that streaming data and make predictions. That has been repurposed back into the ICU, so for something really, really good. So streaming analytics, real time. So we've been able to predict which patients of ours in the ICU, which neonates are going to crump in the next 12 hours. I mean, think about that. And then I would offer, it was just put on many of you have a product called Airstrip. Airstrip, it's a handheld that just sort of would give telemetry data and fetal monitoring data, but remotely. So if you were on call for OB, you could be at home and just see how your patients were doing without having to go in. But now all that's being delivered on a mobile device. Right? So again, mobile device, streaming data, analytics, all coming together, available, on an iPad at your house. I mean, it's amazing. And imagine getting that alert. Hey, bed 4 is going to die in the next 12 hours unless you do an intervention. Now, my mother's an ICU nurse. I thought she was an amazing ICU nurse. She knew those patients, right? She'd be like, something's not right, call somebody, right? I mean, but how do we standardize that? How do we reproduce that so that the quality of care across the hospital and across the community? And then patient similarity. We're starting to take all of the patients in a community, look at their outcomes, look at the inputs that have occurred. So again, we'll just say congestive heart failure patient, those who are putting on an ACE inhibitor, those that had an exercise program, who got better, but drill it down to the sex, the age, the demographic, right? So really start to individualize and personalize care. Again, something that, you've been in medicine for a while, you do intuitively. We're now being able to capture that and do it for populations. And then lastly, just on an amazingly interesting, cool, wow, cognitive computing. Any questions on any of those types of analytics? Because I think they're all just game changers, and they're all in their infancy. And except for a dashboard where you get to see your patients, everything else is really, I think, pretty cutting edge. It's coming. Big hospitals are using some of these, but it's gonna make it to all of us. All right, 2011. IBM was celebrating its 100-year anniversary. And IBM does a thing called a big bet, and it turns out when they say big, they mean big. So they put $1 billion on the table to create something new and different. And that something new and different, I think we typically refer to it as artificial intelligence. But I think artificial intelligence over the years has gotten a bad rap. Just, there was HAL from 2001, and just, there was movies made on AI, and things went horribly awry. So, been rebranded as cognitive computing, but really at the end of it is, can we start to talk to a computer, and will it talk back to us, and will it facilitate our decisions? So, to prove a point, you got to go somewhere. IBM decided to play Jeopardy against the two reigning Jeopardy champs for charity. And then you can pull, if you've never seen it, you can watch the whole thing, the final on YouTube, watching Watson play Jeopardy. And some things, just amazing, and then others still a little complicated. Like I think the section was QWERTY, like a QWERTY keyboard, and I think Watson was just like, I just literally don't know what you're talking about right now. But for many others, it did very well, and you can see it ultimately won. And there was a moment in time that I think the both champions say, this is something that we can't believe occurred. We'll take a little break.
Technology has helped us go further, go faster, go to the moon, solve problems previous generations couldn't imagine. But can technology think? Watson can. IBM Watson is a technology unlike any that's come before. Because rather than force humans to think like a computer, Watson interacts with humans on human terms. Watson can read and understand natural language, like the tweets, texts, articles, studies, and reports that make up as much as 80% of the data in the world. A simple internet search can't do that. When asked a question, Watson generates a hypothesis and comes up with both a response and a level of confidence. And then Watson shows you the steps it took to get to that response. In a way, Watson is reasoning. You don't program Watson, you work with Watson. And through your interactions with it, it learns, just like we do. Every experience you give it makes it smarter and faster. But in addition to learning, Watson can also teach. A new generation of doctors are helping Watson learn the language of medicine. In turn, Watson is helping teach doctors by providing possible treatment options. Watson is learning the language of finance to help investment advisors recommend the best way to plan for retirement. The IBM Watson Engagement Advisor can react to a caller's questions and help operators find the right answers faster. The IBM Watson Discovery Advisor helps researchers uncover patterns that are hiding in mountains of data and then share these new insights with colleagues. With Watson Analytics, you can ask Watson a question, and Watson can show you what the data means in a way that's easy for anyone to understand and share. The The IBM Watson Developers Cloud offers software vendors and developers the technology and tools they need to take advantage of Watson's cognitive power. Accessible on the cloud, anytime. Watson needs you. This generation of problem solvers is going to learn much faster with Watson, and Watson in turn will learn much faster with us. Developers will solve new problems. Business leaders will ask bigger questions. And together, we'll do things generations before couldn't dream of. What will you do with Watson?
It's great marketing. But cognitive computing, artificial intelligence, this is the next realm. Google's working on it, Microsoft's working on it, so this is, it's a wonderful, IBM specific, but this is sort of the next generation of computing. Two things I'll just mention from the video. If you get a chance, so when Watson was answering questions on Jeopardy, Watson would put a differential diagnosis down of top 3, and then would calculate where in that differential the probability of a correct answer was. Right? So again, feels the same, right? Feels like when you were in medical school, what are the top 3? What are you thinking? Why are we thinking these, right? And then Watson's able to go back to the source, because I think it's important that we all go back to why, right? Oh, that article in the BMJ was terrible. I disagree with that. And that's okay, right? So let's retrain Watson. And then the other is, so pharmaceutical companies, one of the big issues is getting drugs out to market faster. There's just an endless host of information that's never been used because they didn't go well, right? But imagine if we had that information, and that's what the pharmaceutical companies are using it, to get trials done more quickly and to get data out the door. And here, Sam Nussbaum, the WellPoint Chief Medical Officer, imagine using Watson Analytic to consider all of the prior cases, the state-of-the-art clinical knowledge, the medical literature, and best clinical practices to help a physician advance a diagnosis and a course of treatment. And I'll show you I'll show you what that could potentially mean. And this is about as techie as I can get. And I just want to give you sort of a sense for where we are in history on this topic. 1900, computing was tabulating, so we just counted stuff. It was a big deal. We were able to count the American population, and that was important. And then 1950s, we started a thing called programmable computing, and that's where we are today. Again, if anybody's taking a programming class somewhere along the line, you program, if then, do this, don't do this. Very simple. And what we do is we keep making better programming, and we keep making faster chips to read the programming, and we're doing pretty well, right? I mean, it's incredible where we are with it on technology. So cognitive computing is, how does the brain think, right? When you and I are walking across the street in the rain with cars, right, we have input, we're having a conversation, we're doing all of that in parallel together. Right? This is not, it's not a started, well, let me look, right? It's all done in parallel, right? This is the way the human mind is formed into a cognitive system. Now imagine, right, so this is just imagine the future. If we could take in your genomics, your clinical note, your phenotype, your genomic data, your demographic data, your social data, we can do this now. We take your tweets, your Facebook posts, and we can put all that together to better care for you. Right? So we know now if you have a certain level of tweeting and posting and it drops off, and this is for service members, this is a note of alarm. Right? We worry about suicide. We worry about mental health. It's been reproduced time and time again. Right? So, but again, the goal is to start to mix all of this data together into helping make best decisions for our patients. I'll give you 3 use cases. One of them was the first one that we came out with in 2011, and this was Memorial Sloan Kettering Cancer Center up in New York City. And I'll just show you isn't that a beautiful user interface? Has anybody seen anything that simple on an EHR screen in a long time? So I'm just happy that people are now hiring human factors engineers to bring to clean up, right? We all dream of a Google-like page. Like only the data we need. I mean, we look at our EHR, we look at Word, and we're like, oh my, you can't put every requirement on every page. It appears you can. So a patient comes in, and I'll give you the example. She's a 28-year-old, 32-year-old Japanese-American woman. She's got breast cancer. She does not want to lose her hair because she's a teacher. So Watson would reads that's going on now, reads her clinical note, pulls out the essential data, asks the attending, hey, we're missing this one genetic test. If you could get that information, oh yeah, we have it. It just wasn't included in the note. And then Watson takes that and puts it all against the entire corpus of literature on breast cancer ever published. In addition to the Memorial Sloan Kettering protocols and their secret sauce. And comes back and says, if you do this protocol, your 5-year survival rate will be this. If you do this one, she will not lose her hair, but you significantly decrease her 5-year survival rate. Like, go have a talk with the patient now. And if you're like, God, where did that data come from? You can go back to the source data. So just give you, again, we had to start somewhere. We started with cancer. People are working on renal failure. People are working on, what I personally love is, I think of the Holy Grail as clinical decision support right at the point of care for diagnosis, right? So Institute of Medicine said this year, we're still up at about 17, 20% of misdiagnosis up front. Wouldn't it be cool to have sort of I didn't sleep a lot last night. I got a lot on my mind. It wouldn't be cool just to have a little like, hey, did you think of this, Michael? I'm like, oh, yes, thank you. And make sure we get to the right diagnosis up front. I think this one is just great for getting paid. Right? So you put a referral in, it hits off of Watson at WellPoint, and it approves it within 3 seconds. Right? So we don't have to fax it, and a new employee over at WellPoint doesn't have to read it and go check it against someone, see if it's the right thing, and call you back. Right? Let's try to standardize it and speed it up. So within 3 seconds, you get your answer back for a referral. Pretty good. And then this is at the level, so we had physician, now we have the payer, and now this is at the layer of the patient. So I mentioned in the video, people can just come and build on top of Watson now if they want. There's like a Watson in the cloud, you go build, you put an application there. This application is one of them, and much like Yelp where it says, I want Italian food, and it tells you where the nearest Italian food, this takes your information, knows you as a patient, and says, there's a Serrani's Italian restaurant down the road. Your blood pressure's been running high. Here's what I'd recommend you eat off the menu. It's like it gives you that down to the personalized level. You're going to see that term more and more, personalized level. And then, just very interesting study, and that's the entire nation of Qatar is having their genome sequenced, and they're just going to start to look to see what trends there are in the population. Qatar only has about 350,000 people in the whole country. Everybody else's workforce that's been flown in. But the actual natives to the country the government's paying for this to see, what the genomic profile looks like, what your social demographic profile looks like, your age, your weight, your height, and then what does that mean in terms of your health. So I don't know if anyone's ever seen this. This is the Gartner Generation 5 EHR model. And again, I think if you've been around long enough, you remember the old days. Maybe we would scan, that was a collector. Then we would do a Word document, and that was our EHR, right? I remember my first EHR was an Excel spreadsheet. I still don't know how to use Excel, but I could type. And I would be able to keep care of my patients on that. And then the helper, nowadays, you put a drug in, and the patient's allergic to it, and the system's like, they're allergic to it. You're like, thanks, helper B, that was great. Like, you saved us all a lot of problems. But advanced analytics, predictive analytics, now we're starting to say, well, it's kind of a colleague. Like, hey, that's good. And then I think if we can put some cognitive computing, advanced analytics, really have a mentor in the room with you when you're seeing a patient, that we all know the physician who just seems to know everything. But imagine if we could reproduce that and scale that across our enterprise. All right, so aging population, more technology, and then here's, there's a good and bad side to this, so I'll just share with you what I think's coming. I'm just the messenger on this one, but I want to share it because everyone's wrestling with this. So if you're running a hospital system, running a clinic, running a group of practice, or a physician in any of the above, everyone's struggling with this. I meet with CEOs of hospitals and they close the door and they're like, I don't know what to do. I'm confused. Like someone has to tell me I'm worried. And this is a recurring theme. And the answer is, it's a work in progress. It's a hybrid model. That's what's so confusing, right? We're paid for volume still, but you're starting to smell value, right? So if you break the numbers down in the US, we're at about 85% payment for volume, but 15% for value. And the government is pushing to make that 15% 85%, right? Like they're trying to swing it the other way. And that goes back to cost and outcomes. Does anyone run a patient-centered medical home? Do we love it? Do we hate it? We have one love? We'll take a like. One like. Paul Grundy, if anybody, Dr. Paul Grundy, he started a thing called the PCPCC, Patient-Centered Primary Care Collaborative. It's sort of the home for patient-centered medical home. The data on patient-centered medical home has been pretty good consistently in all 50 states. The federal government has adopted patient-centered medical home. Pennsylvania is a big user. States are adopting it. And really they're doing it because cost goes down and quality indicators. Again, we can argue whether those are the right quality indicators, but the ones that we have today go up. So the patient-centered medical home, and there's more and more incentives coming towards this sort of team-based collaborative care. I have to give a shout out to the impending trend of mobile. I don't know where your personal EHR is, but the next generation of patients coming through, they want to schedule when they come home from work. Or they're laying in bed, they want to schedule their appointment, or they want to email you or text you, right? How do we do that securely? I mean, we're moving to a mobile environment. That's not a groundbreaking statement, but healthcare has been slow to adopt. But I think we're going to be forced into this just by our patients as the millennials move on. Telemedicine, we hadn't been paid for it before, so we stayed away from it. We gave a lot of reasons why we didn't like it, but it was really we just didn't. ATA just hadn't done the lobbying that needed to be done. They've pretty much done it for 50 states. The money's still not as good, but the patients love it. And the outcomes are, the data that's being published, the outcomes are just as good. I have to tell you, I just got an email the other day from IBM, the HR department. I was getting nervous. I'm like, oh no, okay. And it was, hey, Michael, we want you to take advantage of your new insurance benefit, and that's telemedicine. And I can get on essentially Skype. I have a bronchitis, I have sinusitis, and they'll e-prescribe. I know you just got to take a deep breath on that one, but this is coming. And I share this with you, this and this. If you're in a group, if you're practicing, you got to have a strategy for this. And to turn away from it, I don't know is the best strategy for long-term survival. So what is our mobile strategy? What is our telemedicine strategy? And then what is our strategy to compete against this, right? Where the patient lives, their life flow. I mean, we're going into CVS. You can't even find the pharmacy anymore, right? I mean, I go to Wall. I can't tell you how many times I've been in and out of Bentonville, Arkansas. I didn't know where it was. I've been in and out of it 20 times now. I mean, everyone's interested in healthcare, and this, I think, this is going to be a competitor. So how do we address this with some modern technologies? All right, 3 slides on from the Office of the National Coordinator. The Office of the National Coordinator is a group under Health and Human Services. Office of the National Coordinator is who put forward meaningful use stage 1, 2, and soon to be 3. I think this is a good statement. Enabling delivery system reform through health IT and health exchange. So this is the government's plan. Again, if you're thinking like Melissa Schwartz, who pushed me against the wall and yelled at me about the EHRs, if we're thinking that it's going away, it's not. The government wants to enable system reform through health IT and health information exchange. We got the health IT part down, right? Everybody bought their EHR. Hopefully you bought one that's going to be around in a couple of years. If you have any questions, which one, I'm happy to tell you which ones. But health information exchange, this is where none of us have jumped on the bandwagon, right? So there's going to have to be money and policy behind that, and it's coming. So these are her slides, but I pulled a couple of things out in red. You know, better care provided at a lower cost. All right, thank God, like the government's aligned with what we're thinking every day. You always worry, like the government comes out like, and to deliver a better user experience. You're like, I like it, but it's not really what I was thinking. Better care, better cost. Care is provided, providers are paid, information is available. So the ONC has heard the complaints, and it's been all of us in all of our bodies and our, you know, we've complained collectively. And at the end of the day, even the government can only take so much complaint, and they're like, we probably need to do something. So they know that healthcare reform is needed in regards to payment. So that's coming. It's going to come slowly. Changing how providers are paid, moving from volume-based to outcome-based. And I will tell you, this is my personal opinion, ACOs, accountable care organizations, have been hit or miss. They haven't tweaked the numbers correctly. On a cool note, the ones that have been successful have been physician-led. Right? No surprise. The ones that have been sort of hospital administrator-led, they haven't been as successful. But physician-led ACOs have done okay and made out. What's really made out, though, has been bundled payments. The government loves them. And I really, Karen DeSalvo just stepped down. I thought, surprising everybody. But we're going to see more bundle payment. Right? So we see a couple now for procedures, hip and knee. You're going to see for a lot more. I think about 50 more things. So if there's a bundle payment, now we sort of have to think about care at home, coordinated care, the care transfer, information exchange, other providers involved, patient-centered medical home. I mean, it gives you time to think about some new things that need to occur in your day-to-day practice and the technologies that will underpin some of that. And then transparency of cost and quality. You saw the first, I'll use a Navy term, you saw the first shot across the bow with the release of the Medicaid data, right? I mean, we fought that for years not to have that release, but that was step one, cost and transparency. So we're going to start shipping data out, and the government knows how much things cost, right? Because they're still the big provider of cost, of payment. So these two things are about to come together. I would offer just to get ahead of that, right? Begin to understand. You know, does anybody know what the average U.S. citizen costs to take care of? Just in a general?
12,000.
Yeah, so 12,000. It's not that much. I mean, it's a lot. It's around $7,800. Europe running about $3,300 throughout the across the pond. So again, just to give you some idea, I mean, this is all published knowledge, and the U.S. government is trying to drive that down. Bundle payment is the way that it's going to come out right now. So what do you need for a successful bundle payment? Again, I'll go back to Sioux Falls, South Dakota. The orthopedic surgeon does surgery and then has contracted to Good Samaritan. Good Samaritan has hired a bunch of very compassionate high school grads to watch a monitor to see if it flags red or yellow or green for if someone isn't getting up or getting up too much, right? So if a woman gets up, 17 times during the night to go to the bathroom, we're like, we should probably find out and check her urine, right? I mean, stemming off a readmission for that bundle payment, stemming off bad care. So again, we're going to see more bundle payment. ACOs, I think that the government's got to go back and tweak the numbers. I don't know what else to say. Like, they just need to go back and tweak the incentive numbers. Thousands of hospitals, there's the bundle payment, 50 conditions and procedures. So you want to keep your eye on what those 50 procedures are, because you can make out well, because if they're things that you do well already, you'll make more money for them, and the patients will benefit, right? So it's a win-win. But I mean, I'm talking about like congestive heart failure, stay. Diabetic ketoacidosis, stay. Right? Like those are going to be bundled, is where we're going. Quality scores. We're all going to start to have quality scores posted on us. It makes me think of the Navy. Every time you landed a jet on the aircraft carrier, your landing was posted. Right? We're very competitive as a bunch. And we actually all do well when we hate it, but once it's posted, we're like, oh no, right? Now, quality of data is important, but there will be a moment when it will be posted. If you get it, I'll just offer that up as you can pull this off online. The 10-year vision to achieve an interoperable health IT infrastructure. Sharing data, something we hated to do. We did it with a fax machine, and that was our sharing. We will need to share. The payment reform will, meaningful use stage 2. Is anybody attested to it? Is anybody doing meaningful use stage 2? One guy. 2, yes. Did you all do stage 1? Did you take your money? It was pretty easy money. It was just go online. Okay. Stage 2 is hard, right? And I think the big part of it, and it may change, so I just want to share this with you, so give it some thought. Stage 1 was 90 days. You had to attest to 90 days. Stage 2 it's a year, and nobody can do a year. Because all of us are switching our EHR out. Like, well, I don't understand. I'm moving from this one to this EHR. How can I get a year on that, right? So I would offer our associations, our biggest complaint, our biggest ask of ONC has been to change it back to 90 days for stage 2. And I think they're going to give. I do. That's my personal take. And then I think it'll be a little easier. And again, a lot of it just depends on the technology that you purchase for stage 1, because all the technology vendors need to keep up with what stage 2 is going to be to support you. Otherwise, you're going to get rid of them as well. No easy task. But being interoperable, having patients be able to download their record. These are things that we just never thought about before. We're like, hey, we'll give you a copy. But now they need to be able to find. They need a web portal, patient portal. They need to be able to schedule. You need to be able to share. It's going to be tough. And here it is. This is the final. Just again, some of you may or may not be around for this, but I'll just give you where your government, where your taxpayer dollars are going. Ensure providers and individuals can send, receive, find, and use a basic set of essential health information. And right now, that's really just like a CCD document, it's called. It's got demographics on it, age, address. It's got your summary of care, and it's got your medications and your allergies. Your EHR has to do that right now. It has to be able to send it. Some people are using a thing called Direct, which is really just an email, but a secure email. So 2017, right? We got a couple of years for that, and if you have the right EHR for that. But look at 2024. This is where we go to precision medicine. Precision medicine is, that's personalized medicine. And that's personalized to age, height, race, zip code, genomic makeup, social structure. We're not going to give expensive drugs that don't work on people anymore, because we're going to know that they don't work. We're going to personalize medicine, right? Personalized in many formats, but personalized in a scientific format as well. All right. So, aging population, just presenting multiple problems for this nation and for the world. More technology, we all believe is going to help us solve our dwindling quality, increasing costs, dwindling provider base, and new care models. It's all a work in progress. If I was going to bet, I would bet on bundle payments. Be comfortable with bundle payments for your particular specialty, and If you don't have an IT guy or girl who can help you, make sure you're on the right EHR platform, that you can do what needs to be done to attest to the next level, right? You probably want to just talk to somebody. Again, I wouldn't offer learning this if you don't know it. But grab somebody. Come on, everybody's got like a 17-year-old nephew somewhere who can reprogram. But let's make sure that we all get the money that's been allotted for us for meaningful use stage 2. Meaningful use stage 2, and then the stick at the end of that is 1% penalty, and I think it's going to go up. And if you look at the true cost, it's probably 8%. When you look at total cost, right? So it's good. We're going to feel the penalties if we're not on board. I mean, I think the government. This goes back well before President Obama. I mean, President Bush and before talked about how health IT was going to help solve our healthcare crisis. So this is my email. This is my phone number. I do my best work on text. So if anybody just wants to shoot me a text, a question. It's the only way my family knows how to communicate with me now. I'm happy to answer any questions. I thank you so much for having me today, and I hope that gave a little insight into sort of our collective future together with technology.
Thank you so much. What an incredible view to the future.
Yes.
Okay, we'll take some questions. Let's come to the microphone. If you want to queue up there, please feel free to.
How do physicians survive this transition where we're expected to be productive and we're being thrown a inefficient EMR system that just makes it harder for us to do our job? And
yeah.
I mean, how do we survive this?
Yeah, so it's a great question. And anybody remember Rodney Dangerfield, Back to School? Like one question, 10 parts. So I'm going to start with the easy side of this. Have you bought an EHR? Do you have one? Right. Epic. Okay. Perfect example. So, in the office, yeah. So you have to implement the EHR, which hurts, right? It's painful to do. And where we all stop is at the implementation. The next step of that is the optimization. And this is critical for all of us. We have to optimize the workflow. We have to optimize the tool that we are provided, and we don't. Right? Whether it's templating, whether it's dragons, like there are more tricks and trades and optimization techniques available than any of us know. And I say that because, I delivered to 70,000 providers the worst EHR ever. And it was in the military to the world, right? So I received one email a day from each of them telling me how much they hated me and the EHR. And even I was able to go get teams to go out to optimize their workflow and to use the system better. Right? Again, I'll just go to, if somebody sat down with you and told you how to make a PowerPoint better, like, hey, it's click here, you're like, oh, I didn't know that. So I had a guy named Tony Inne. I deployed to the White House. And the White House called me back. They're like, what was that? It's horrible. Like, hang on, I'm sending you Tony. Tony went in, and then they all called me like, oh, we had no idea. So, and this is true for Epic, Cerner, or, pick one. The next step is the optimization. And then to support there's a way that you practice, right? There's a way that you see patients. Your tech checks them in and signs off on something, right? I mean, and the system wasn't initially configured just for that. That work needs to be done now. And I think that's actually harder at the end of the day. And I think with that, so you look at the numbers, a deployment of an EHR, you have a decrease in productivity by 25%. Okay, documented. The goal is to try to blunt that to maybe 20% or 15%, but nobody's been able to do that. But when done correctly, you can then increase your efficiency.
But the question
Yeah.
Whenever the optimization people come around, they never do what we want them to do. They only do small bits of things that don't benefit us, and there's no individualization being allowed.
And when you say individualization, you mean
Per doctor.
Yeah, but you mean in the system?
In the system.
Yeah. So it's a great topic. I won't belabor it, but I will say, when it comes to software in the world, you have two choices. You can change this is anything, this isn't just medicine, this is when the ERP system, or this is, your airline system, you can either change the way you do it or try to change the software. Where do you stand in that one?
I'd rather change the software.
I know, but you're probably not going to change the software, right? I mean, there's configurability built into all the software, so you need to make sure you maximize that configurability, and you'll get a lot out of that configurability. I got to tell you, I would offer that the folks that really know how to optimize, and there's a shortage of them. So if you're not getting the A team, the varsity team coming in, it's because they didn't bring the varsity team in. There's a lot you can do to configure it to make your life way better. Again, it won't be perfect. You're not going to get, your spouse isn't going to love you more, your dog's not going to spend more time with you, but it'll be better. And you really can become more efficient. Trust me, I've been through this 70,000 plus times. I've been on both sides of this. You can make it more efficient, but there's going to come a moment where you're going to have to change workflow a little to support the software that you purchased. You just got to find that right balance. And I think ultimately you'll see that, if you're keeping track of your numbers, you see them down, then you can see them come back up again. And I think you can exceed. And, with correct billing and everything, I think you can see numbers go up. Again, I don't know if that's enough, but done correctly, this is the curve, the natural curve that occurs.
Michael, I'll ask you a question from the podium here. Once we get our individual systems tweaked, none of them talk to each other. So
Right.
where are we with health information exchanges?
Yeah. So, every time there's been a health information exchange, the government has put money in and said, go do an exchange, and we all did the exchange, and then the government said, all right, that's it, and then we all disbanded the exchange, right? That's where health information exchanges sit today. We will have to share a summary of care document. Again, this is just basic stuff. And that to get your meaningful use stage $2, you will have to share. Now, you personally, are going to rely on your vendor, whatever software vendor you went with, to be able to support that. Right? So if they don't do that today, you got to call them and ask them, what are we doing about this, and when will that be ready? The major vendors, if you're on a major vendor, they all do it. They don't do it eloquently. It doesn't fit workflow. I mean, just back to your earlier point, we're not there. We are in the early stages of sharing. And, on a technical note, we're sort of sharing a PDF, which is just sort of a document. I mean, there's nothing rich in that. It's just, but it's better than what we had before, if your fax machine wasn't working.
Thank you very much. And will you be around for a few minutes?
Oh, absolutely.
afterwards?
Yeah.
Okay.
Thank you.
Let's give
Thanks.
Dr. Weiner a hand.